Queens. Welcome to the Sister Circle podcast, a podcast dedicated to providing candid conversations, information, and resources regarding women's health, mental health, motherhood, and wellness. And I am your homegirl and host, Faith Alaribe. So go ahead and get comfortable, Queen. Let's dig in. Hey, Queens. I'm excited to have a part 2 to my conversation with Dr. Soyini Hawkins, this time about endometriosis. Endometriosis affects about 200 million women worldwide and about 1 out of every 10 women in the United States. Yet the disease is often misdiagnosed or missed altogether. Lack of education and awareness is one of the primary reasons it goes undetected. And research shows that the average time that it takes for actual diagnosis is anywhere from 7 to 10 years. Mind blowing. So Dr. Hawkins will talk to us about all of the symptoms that are associated with this chronic disease, how to go about getting a diagnosis, and the treatment options. So let's dig in. I want to switch and talk about a topic that I just haven't heard a lot of information about and around, but that of endometriosis. I know, I didn't know, but now I know that there's a lot of women who are out there that are really suffering. So I would love to talk a little bit more about that. But I guess for starters, what is endometriosis?
Yeah. So endometriosis is another one of those that can be quite debilitating. Statistics say it affects 10% of the population, but that number is much higher. There are many women out there that are suffering and undiagnosed. Endometriosis, it takes sometimes 7 to 10 years on average to even just get to the definitive reason why I'm suffering with pain. Endometriosis is when the lining of the endometrium, again, that all women have, can actually implant itself in a ectopic location, so where it should not be. So in the pelvis is the most common location. And there's this theory of retrograde menstruation saying that when you're menstruating out and you're having your cycle, you could be putting some blood back into your pelvis through your fallopian tube, like they're just going back through your fallopian tube and implanting themselves. And when they implant, for people that have endometriosis, it gets stuck there. Like they actually implant into the peritoneum or the skin of the abdomen. And every time our estrogen levels change, which is usually just before menstrual cycles, those implants will get inflamed and cause pain. The inflammation causes pain. Mm-hmm. So that's where the pain that comes with endometriosis, the hallmark of that diagnosis and disease, is painful menstrual cycles. That's how the pain occurs. Endometriosis can be found anywhere in the body. So there are other theories about it being from, embryological implantation. It's been found in the brain and the pericardium and the diaphragm and the thoracic cavity. It's been found on autopsy everywhere. But most women are going to have it in their pelvis. And that's where their pain comes from.
It's interesting as you were talking about the pain that's associated with it. It's like there's always seems to have been like this normalization of painful periods, right? It's like, I just know my period is coming since, being teenagers, right? My period's coming, I'm going to be in pain, and it's normal to not see, your homegirl Lucy not be in class for 2 days out of the month, right? It's not normal.
It's not normal. Mm-mm.
It's not.
Yeah.
Okay. So,
what you just said is key, and we have to stop that. A part of stopping that normalization of pain and heavy bleeding is talking about it and helping women realize it's not normal. If you are having to take Percocet when you're on your period, that is not normal. You might have some cramps. Your uterus will cramp a bit. You might be able to take a Motrin or Advil or an Aleve and keep going. But when it gets past the point of being able to work through and be productive, I keep using that word, go to school, go to work, go to the kids' soccer game, all of those things, make dinner. When you can't do that because you're on your cycle, that is not normal. It shouldn't take you out. Your cycle shouldn't be taking you out. Something is wrong. And it could be a number of things. We talked about probably 20 different reasons why that could happen. And two of the biggest factors are endometriosis and fibroids.
Interesting. So aside from like painful periods, what are some of the other symptoms that are associated with endometriosis?
Yeah, a lot of times, depending on where the endometriosis is, it can affect so many things in your pelvis. So it can cause painful urination or frequency of urination if it's close to or on your bladder. There's an associated actual bladder syndrome called interstitial cystitis, which some women might be diagnosed with. It can also cause painful bowel movements or blood in your stool if it's gone through and through your actual large bowel. It can cause painful sex. That's a big one. Painful sex because usually the location of the actual endometriosis implants and that inflammation by your cervix. And for some patients, they have pain in between their cycles. So intermenstrual pain is what it's called, pelvic pain, intermenstrual pelvic pain. And they're in pain all month long. Yeah.
Oh, man.
And then the big kind of hidden one that is not as obvious is infertility. So again, so many factors that can affect fertility, right? Infertility sometimes is what will get patients to the diagnosis of endometriosis.
And so you said that the average time that it takes to get diagnosed is anywhere from 7 to 10 years. That's a long time.
A long time.
That's a really long time. So how is it diagnosed?
Yeah. So it's hard to make the diagnosis. And that's why it's so long for some women from when they start to first notice the changes or even complain about it to their doctor to the point where someone says this is endometriosis or likely to be, because it's not something that we can see on the ultrasound. It's not something that we'll be able to pick up in the blood work. There's no non-invasive way to diagnose it. Not an ultrasound, not a blood work, not just usually a simple physical exam. Usually the exam is quite what we call benign or normal. Endometriosis can only definitively be diagnosed surgically, usually through what we call diagnostic laparoscopy, a camera in your belly button to just look and see it because it has very hallmark look to it in the actual pelvis. And even then, sometimes it's missed by generalists that they're not used to doing these type of surgeries. But you don't have to have surgery to get treated for endometriosis. There's something that we call empirical treatment or empirical medicine where your symptoms straight up sound like you got endometriosis. The reason that it takes so long to get to the diagnosis sometimes is putting around with, like I said, they just, you go to the doctor and they're like, okay, here goes a pack of birth control pills. And I'm not saying birth control is bad. I spent my whole first year of life on birth control trying to just get through these degrees. So I'm not saying birth control is bad, but getting to the why is so much important than just getting treated, because again, it delays the diagnosis for many women. And that delay in diagnosis sometimes can have serious adverse events like infertility because you just didn't know there was an issue, and for so long it's kind of festered. And then the other part is what we just talked about, normalizing pain. So there are many women who go to the doctor year after year, annual after annual, and say, my cycles really hurt. And their doctors are like, it's kind of a part of being a woman. That's the problem. Right? So that is why that diagnosis to endometriosis can take so long.
So you talked about getting the diagnosis and the different ways, and it's like, oh, you can either do it laparoscopically in your stomach, or you said that there are ways that it's like, oh, it just adds up and you've been diagnosed. What are like how can it be treated? And is treatment like this fluid thing? It's like, oh, once I'm treated, I'm done. Or like, what does that entail? What is treatment like?
I wish. Endometriosis is a chronic disease, therefore it's a chronic diagnosis, mainly because while we're menstruating over our menstrual life, we can put down new implants. Because remember, I said it's your endometrium. It's what you menstruate. That's the same thing that's kind of implanted in your body. So as long as you're menstruating, you have the potential to make new endometriosis. So a lot of the treatment is centered around, okay, where are we in our life? What are our plans? What are our goals? I think treatments in medicine, especially in gynecological medicine, should be centered around what the patient's treatment goals are. Are you like, okay, this ain't taking me out. I feel like it's not normal, but I'm managing it with pain medication, with Motrin, and that's where I'm comfortable there. That is an okay place to start for some women if it's enough. If it's not enough, sometimes we do move into hormonal options, such as birth control. Like I said, it's not the devil, it's not the enemy. We just need to know what we're treating, right? We just don't need to throw it at them. And so many doctors will start off with some type of hormonal regimen, basically to just even keel, get their baseline of what their hormones are doing on just like a constant level. Because remember, I said it's that fluctuation, it's that drop in the estrogen that will actually stimulate the inflammation and pain of endometriosis. So many women will have the diagnosis, even if it's a soft diagnosis, get on birth control pill and their pain goes away. And then it's confirmation. It's not like concrete confirmation, but it may be confirmation that they have some elements of endometriosis in there. And that's okay for them to be treated like that, because again, they were treating the inflammation, which festers into other areas of complication. And then beyond hormonal options, there are options to actually decrease their hormones, which is just a whole nother class of medicines, because again, the estrogen, right, that big word, that hormone that we have to claim because we're women, is our hormone, but can cause a lot of problems. That estrogen can be brought down a level, and sometimes that works well for patients to control their pain. And then patients that come and seek me are usually to the point where they've tried all of those things, or for some reason they just don't want to try all of those things, whatever their concerns might be about it, or the fertility factor, the fertility doctor sent them to me because of suspected endometriosis or confirmed on for imaging, because they're cysts, they have cysts on their ovaries. That's the only way you can see it on the imaging, and they have to have surgery, and that is the next step.
As far as like fertility is concerned, is endometriosis, it's kind of like you have endometriosis, and is there an automatic assumption that it impacts fertility or not?
Not necessarily. Just like the fibroids, it's not always to blame for fertility issues. There are many women with endometriosis that are able to get pregnant, and their pain usually gets better when you're pregnant, because you're not having this. Yep.
You're not menstruating.
Exactly. And you're not having those dips in your hormone levels, right? So that's the kind of running joke with endometriosis, or not joke. It's not a joke. It's reality. With endometriosis patients, is the only time I'm not in pain is if I'm pregnant or when I go through menopause. And that's because of the hormones that naturally will change during those two periods of a female's life. Yeah.
Gotcha. So, since this disease, it seems like it's complex. When you are someone who's like, okay, I'm to the point, I'm tired of these painful periods, I'm tired of having to take off of work or what have you, where do you start? Like, how do you begin to have the conversation with your doctor? Like, where do you start? And how do you suggest that they do independent research again about this particular topic?
Yeah, the research it starts off the same way. It's usually a real understanding of, these are my symptoms and these are the changes, just in paying attention to our body. Like, these are the changes or progression that it's had over time. Like, sex didn't used to hurt and now it hurts. Or my bowel movements I used to never have any discomforts. Now, every time I come on my cycle, like, it hurts to have a bowel movement, or I'm seeing blood in my stool. Like, these changes that our body very intrinsically would just tell us that's not right. Keeping track of that and bring that to your doctor. And for some patients, they will do that work of a Google search even. It might be like, I got IBS, I got, I got endo, they done got about 10 diagnoses out of that Google search, which is fine. And then you need to go have a conversation with a doctor. Again, what will keep people at home is when they feel like they're not being heard. I believe in second opinions. If you go to your doctor and you're verbalizing what is going on and you're not getting anything back, you're getting dismissed, or you're not feeling like there's a good understanding about what your options around your symptoms are, because just because you know what I'm saying, like your stomach bubbles doesn't mean something's wrong. Like you might have gas. You might need to go take a probiotic, or maybe I'm not a doctor for you. Maybe you need to see a GI doctor. You know what I mean? But to be dismissive of that or not kind of explain what might be going on, go get a second opinion. If you're not comfortable with what your doctor is giving you, there's nothing wrong with getting a second opinion. And many a times, most people will circle back around to their doctor because they might hear the same thing twice and then they get comfortable with it. That's okay too.
Gotcha. And so I think that lastly, like, what are the treatment options that are associated with endometriosis?
Yeah. So the hormonal medications to decrease the hormone, and then surgery. And in surgery, I would say see a specialist. I would say if you're going to have endometriosis surgery, your doctor, if they're generous, will usually either say, this is a question to ask them. Are you comfortable treating endometriosis? And if there's any hesitation, or if they're like, I can diagnose it, you need to go see a specialist. Because it makes no sense to me that there are some doctors that will take their patients to the OR with this suspected endometriosis, or I'm taking them for pain and it's not something that's obvious, like an ovarian cyst. And they'll get in there, look in, say they got endometriosis, close them up, and then send them to me. And I'm like, okay, you should have sent them to me, because I would have resected out that endometriosis and they would have woken up with a 70% decrease in their pain. You know what I mean?
Mm-hmm.
So it's definitely a process to get into the diagnosis. And then when you do, options that are your generalist may be able to offer you. And then a point where if you're thinking about surgery, you may want to seek out an endometriosis specialist, or again, a minimally invasive gynecological surgeon, because most of us have been trained to deal with endometriosis. And then there's something called ablation, which a lot of generalists will do, and something called excision, which most of the minimally invasive doctors will do, where one will burn the endometriosis lesions and one will resect. You do better if it's resected. There's a lot of studies that look at that and look at the information. Some that say there's no difference out there, but most of the studies very clearly say that if you have it resected, you do better, which makes sense, right? Because if you only burn it at the surface and it's deeper and you haven't removed that deeper portion of, you're only looking at the iceberg, the tip of the iceberg, and you're not going to get as thorough of a treatment. You're just going to build scar tissue that'll be harder to remove later. So seek a specialist. And then,
but Dr. Hawkins,
after,
what does resect? What does resecting mean?
Cut it out.
Got it. Okay.
Yeah, not just burning it, but literally cutting around the endometriosis. Remember, I said these are little microscopic lesions on the pelvis. Cutting that out, making your anatomy as normal as possible, taking down the adhesions that might be causing your tubes to be blocked, or, opening up the spaces, removing the cysts on the ovary, getting down the scar tissue, all the things that can come from endometriosis. Sometimes those surgeries can be worse than cancer surgeries. I'm not going to lie to you. They're difficult surgeries. Most gynecologists don't want to do it. So go find a specialist that knows what they're doing. Yeah. And then usually you need a plan after, because it's a chronic disease. So you need a plan to say, okay, how am I going to try to decrease my risk of this coming back? What lifestyle changes may I need to make? What type of anti-inflammatory diet do I need to be on? Like, how can I help myself decrease my risk when it comes to the development of endometriosis, or how I'm going to manage this as a lifetime disease?
So what are some of the ways that you would suggest that folks, manage this?
Yeah, I usually encourage my patients to first think about where they are as far as their goals are in life. Like, are we going to try to get pregnant? The best time to get pregnant usually is right after that surgery, if you're in a position and timing in your life to be able to do so. If we're not going to get pregnant, then how are we going to try to suppress these cycles, which usually circles back around to something like birth control? And if we don't want to do that for whatever reason, we need to, have a definite plan how to address it from a lifestyle aspect. And then we just need to keep up with your symptoms, because unfortunately what we find is that most patients with endometriosis, especially if they do nothing after having surgery done, will probably need surgery again within 3 to 5 years. Okay, and this is a phenomenon I see, I think, mainly because I deal with all of these different elements of women's health, but sometimes fibroid or endometriosis is a late diagnosis that they may not have had younger because of things like fibroids. Right. So even if you think about piping engineering, if you have fibroids that are blocking that blood flow from going out, you can get a pushback of that blood into the pelvis. So sometimes I would say in 40% of my patients with fibroids find endometriosis. When I go in there for fibroids, they never had pain. Totally asymptomatic when it comes from a pelvic pain syndrome, or we just said their pain was because of their fibroids. Right. And they also have endometriosis. So endometriosis is found a lot of time in conjunction with fibroids. And then thirdly, adenomyosis is not talked about a lot. And adenomyosis is endometriosis of the uterus. Right. And that's another one that can cause significant heavy menstrual bleeding and pain. And even more tragically, is not well researched. There are not good treatment options for it. It can affect fertility potentially. And many, many women are suffering. Many women are suffering with adenomyosis, either undiagnosed or untreated.
So how would you go about getting a diagnosis for something like that?
Yeah, that's another hard one. Just like endometriosis, a lot of times it's not seen on the imaging very easily. And from a surgical perspective, it's not something you can cut out. The definitive treatment for adenomyosis is usually a hysterectomy. I try my best to treat patients with medication options to just decrease their heavy bleeding, treat their symptoms, treat their pain, either until they're able to achieve pregnancy or they've gotten past that point of fertility when they're ready to have a hysterectomy, or very gracefully go into menopause where most of these things will fix themselves.
Wow. That's fascinating about how that can fix fibroids and it can fix endometriosis. Why? Why is that?
Hormones, all hormone based. So once that estrogen level starts to go down, that progesterone level starts to go down, you're not feeding any of it anymore. You're not feeding the adeno, you're not feeding the endo, you're not feeding the fibroids.
So if you are someone who is a little bit older in age and probably are close to menopause, would you suggest for them to just kind of like wait it out?
A lot of times I do for my patients, if I feel like their symptoms are to the point where it's manageable. Sometimes simple lifestyle changes will make it tolerable or manageable. Sometimes that patient that's like teetering on menopause, like I'm starting to have hot flashes and night sweats, I'm starting to skip my cycle. When it comes, it's heavy, but I don't necessarily want to have surgery or feel like I need to because I can manage these symptoms. If they give it some more time, they can very gracefully just get down in there. Or we can give them medications, all those medication options that we address that might be able to bridge that gap for them to make it more tolerable until their body can take care of it in a more natural way by taking care of whatever the anatomy cause of the discomfort is. Yeah, I do. If I feel like you're close, a lot of times I'll have that discussion as an option. Some people will take it, and some people like, no, girl, no. I've been dealing with this for too long. I need to be good in my old age. I'm not snatch this thing out or whatever whatever. Again, it's about knowing your options. That's one of them.
Awesome. So are there any suggested like resources or organizations, particularly around endometriosis, so that, women can become more informed?
There are a lot of organizations around endometriosis. White Dress supports endometriosis sufferers as well.
Oh, I didn't know that.
They do. They support fibroids, endo, PCOS, all women, all female anatomy ailments for sure. There's an Endo Foundation, which I have to shout out because I feel like they're also doing a beautiful job in helping Black women to understand that this is not just a white woman disease. Because if you read that classically, the textbook will describe like a tall, skinny, white teenage woman. That's who has endo. And it doesn't leave room for someone that might look the exact opposite to feel like, okay, could this be what I have? But that's not me. That doesn't fit my description. They're doing a good job in making sure that they address that this is a woman's disease. It has no, again, just like fibroids, it has no color or creed or cultural discrepancy disparities. Like it can affect everyone. They're doing a wonderful job in being, very inclusive. And the foundation is huge. And even within these organizations, there's a fibroid pandemic within these organizations. Their biggest claim to fame is giving resources about other either organizations or groups or doctors like myself or, nutritionists, holistic people, naturopathics. Their biggest claim to fame is connecting the patient with what they need to deal with whatever they're going through.
Yeah, I'm really into alternative and functional medicine. That was a large part of my journey as well.
Yeah. If I were going to go back to school to do anything, that's what I would go back to school to do.
You should do it. Go on and go back.
Wow, these children, they school enough. Ma'am. But if I had it in my heart and then God laid it on me to do.
Okay. Well, we're going to pray that God lays it on your heart because no, seriously, I think that, I talked a lot about, the different procedures that I had done. I've had something called Mercier therapy, which really helped to increase blood flow in my uterus, help break down scar tissue. I did like this hormone balancing diet that took my 91 level prolactin levels from to 45 and then to 11. Like I believe in like the holistic care. It's necessary, so
it's the least we can do. I think honestly, I know that some people hate when I say this, but I honestly give credit to the fact that my fibroids have not grown back to the lifestyle changes I've made.
So what would you say? So you said that you cut out beef and pork, but what else? What are some of the other lifestyle changes?
I cut out processed foods. So beef, pork, processed foods. I cut out canned foods, even though I love tuna. Tuna might be the one that I give into because we're not perfect.
Right. I like tuna as well. I know.
I love tuna. Cheese. I like my cheese. I don't do a lot of dairy though, but I might have cheese once a week, every other week with my wine and my grapes. I like cheese. I'm bougie. And then I went natural, stopped processing my hair.
Your hair is fabulous, by the way.
I got rid of the creamy crack. It's a color, and it was hard to do. And I became more conscious about reading labels. I'm not perfect, but I made an effort to try to get closer to, like I said, closer to the earth. And even in the way that I feed my children and my family to try to do things that are going to be healthier for us. My children know what McDonald's is, but McDonald's is like a luxury.
Right.
You know what I mean? It's not a normal thing. It's a treat. Or it's an abnormal, or it's a luxury. So those are the type of changes that I made. And I was that paranoid person that I did my own ultrasounds on myself for many years because I was just always anxious about the fibroids growing back. And then lastly, I cut out a lot of stress.
Man, listen, stress will kill you. It will
kill you.
I
made a very conscious effort that I have many friends in this world. I have great best friends in this world. But guess what you ain't finna do? You ain't finna stress me out because I don't need no new friends in this world. Right? You're not gonna stress me out. I will. It's just not worth my health and my time, or my spirit.
So what would you say, aside from, no new friends, but what would you say you have found to be like the most, or, it could be a couple of things, the most de-stressing things that are a part of your life?
Prayer.
Yeah.
And that to me is everything. I pray over all my patients. They might not know it. They don't have to know it. I pray over every surgery I do. I pray over my children. I pray over decisions I have to make. And it takes it out of my hand, I feel like, and I let it go. And to me, that's the best way that I've been able to deal with stress. Not that I don't have it. I've done a lot of different things this year. I bought a brand new practice. I moved myself. I got out of my comfort zone because God made me uncomfortable. I said, I'm comfortable and I'm good and I'm collecting my coins. So what more do I want? And God kept making me uncomfortable and saying, I have more for you. And I had to listen to that, and I gave it to him, and that was it. Everything else fell into place. So to me, that has been, and I have a praying husband. My husband is a minister, but even if he wasn't a minister, he's a praying man. And he's my partner in all of this. And to me, it takes a lot of stress off of me. I'm grateful for that.
Beautiful thing. Mm-hmm. Awesome. Well, listen, Doc, it has been such a pleasure, like talking to you and learning more about, two really big causes as it relates to women's health. And then just, you got a real different spirit, and it's a beautiful spirit. And so it is my prayer that your practice, I already know that it's booming now, but that it continues to boom, because the energy, the thoroughness and the education that you provided, just me being a complete stranger who reached out to you, I can only imagine what patients receive when they come in and are under your care. So with that being said, if you want to find out more about you, follow along, what have you, how can folks reach you?
Yeah. So the name of my practice is Fibroid and Pelvic Wellness, but I tried to make Googling me and my practice very easy. You can go to getfibroidhelp.com. And on my website, I have so much education. Like, you ain't even got to come to me to know what all these disease processes are and options, because they're all on there, videos, interviews I've done. And then if you want to follow me on social media, because then I post things like post this, it's Soyini Hawkins, MD. So just my spelling of my first name, last name, MD. And that's on Instagram. And that will link you, of course, to my Facebook and everything else. But
so I thank you again, and wish you nothing but blessings in the future.
You too. You too. Thank you.
Thanks, so Doc. I appreciate you. Thank you so much for listening. It is truly my hope that you both enjoyed and gained something from it. And if so, be sure to share this episode with another queen that could benefit. Also, if you are willing and able, please leave me a 5-star review wherever you consume your podcast. That is how we spread the good word, y'all. And in the meantime, be sure to follow us on all social media platforms at The Sister Circle Podcast. And be sure to check out the website, thesistercirclepodcast.com. There you can subscribe to our mailing list to ensure you get reminders about when new episodes drop, and receive our monthly newsletter that's filled with great resources. You can check out our show notes, resources, and blog. And you can send me a message if you want to be on the show, have an idea for the show, would like to collaborate, or sponsor the show. With love, Faith.